hopefully, after my slight debacle, we have Susan Mollen available to do our last talk. Susie, are you there?
Thank you, Mike. I am indeed. I'll just get up my slides. So it's been a fantastic showcase of what work is going on in the United Kingdom. And what I want to bring to you today is some of the work we're doing in Birmingham on idiopathic intracranial hypertension. I do have some disclosures with Invex Therapeutics, which is a spin-out company of the University of Birmingham, and I'll be talking about that a little bit later. So in Birmingham, we've got a translational research, our brain research portfolio, looking at pathological mechanisms and novel therapies. But really importantly, what we've been talking about today is quality and equality in clinical care. An idiopathic intracranial hypertension is a disease well known to many ophthalmologists and neurologists. It has very specific diagnostic criteria that must include papilledema, normal neuroimaging, and a raised lumbar puncture opening pressure. And our patients can have really disabling headaches. They're at risk of visual loss. It's a challenging disease because 90% of our patients, it's associated with being overweight or having obesity. It's a disease of social deprivation. And we're now finding this metabolic dysregulation and an increased cardiovascular risk. And it was through this national network of primary care database in the UK, we were able to see that the prevalence and incidence of the disease is increasing. And really around about a BMI of 30, the disease really starts to take off. But what was unique about this study was it showed that our patients with IIH that were matched to age, gender, and body mass to control patients, we saw this real increased cardiovascular risk that is not explained by obesity alone. And we know from the literature, causes of IIH has been elusive for a long period of time. And we believe it's a disease of oversecretion. And through some of our work in Birmingham, we've now found a real metabolic disease that really determines from your gut neuropeptide axis. Our patients are insulin resistant and they have increased abdominal obesity. So I'm going to tell you a little bit about a bariatric surgery trial that we've done. And one of the sort of starters for that is we know that it's linked to weight gain. And we know that weight loss methods can be quite challenging, particularly diets can be unsustained. And we know that if you diet, you often put on the weight that you've lost within about 2 years. So weight gain has also been associated with relapses of disease. And when we asked our patients in a formal priority setting, they emphasized the real importance of finding out what's the most effective approach to treating idiopathic intracranial hypertension. We hypothesized that bariatric surgery would lead to greater weight loss and greater sustained weight loss. So it's a multi-center randomized controlled trial. We recruited women with active idiopathic intracranial hypertension, and they needed to have a body mass index over 35. And the reason for this is that in the United Kingdom, people are eligible to have bariatric surgery if their body mass index is over 50. But if they have a comorbidity such as diabetes, they could be eligible at a level of 35. Now, idiopathic intracranial hypertension currently isn't a comorbidity. We used the diagnostic criteria, and these were active patients, although they had a long disease duration of over 1 year. And we were quite pragmatic about our approach. It was a shared care decision as to what type of surgery the patients had. So some had a gastric band, some had Roux-en-Y, and some had a sleeve. And the dietary intervention was Weight Watchers. The primary outcome was lumbar puncture as measured by lumbar puncture opening pressure, but we had all the visual secondaries and quality of life measures. The sample size we looked at was detected this difference of 5 centimeters of CSF between the treatment arms. We knew that we would have a withdrawal rate. So based on these assumptions, we recruited 66 women. The primary analysis, which I'll show you first, is intention to treat. So those patients that were randomized to a specific group. We also planned a per protocol analysis because we knew that there would be slight movement between the two groups. So we randomized 66 women, and actually it was a very popular study to recruit to. And the mean baseline characteristics were that of a really typical IIH population. They had a good going intracranial pressure at 35 centimeters of CSF and with evident papilledema. And this is the intention to treat, which shows that we saw a difference of 6 centimeters of CSF at 12 months between the surgery and the diet. And when we look between baseline and 12 months, you can see that the bariatric surgery group lost nearly 9 centimeters of CSF. And again, these were sustained out to 24 months. In fact, we saw a further reduction in ICP over the next 12 months. And these were nicely mirrored by the weight change, body mass index, and reduction in excessive body weight. And so here we can see quite nicely the percentage weight change of the diet versus the surgery. And again, the percentage intracranial pressure change. And what we find really interesting, which has not been seen in the literature before, was we were able to correlate headache severity with intracranial pressure. And not only that, we were able to predict what the change in intracranial pressure would be, looking at the change in headache severity and monthly headache days. This also correlated nicely with quality of life measures. So next, we're going to move to the per protocol analysis. And this is important because we wanted to really explore the differences between intracranial pressure, weight loss, and also the weight loss methods. And here we use a linear high regression model. So again, just to remind ourselves, these are where the patients are. And when we move through, you can see the differences between banding, sleeve, and bypass, with Roux on YPAS being far superior over the other modalities of surgery. And again, this is mirrored in the percentage change in intracranial pressure. And there was a really nice tight relationship at 12 months between body weight and change in intracranial pressure. And again, we saw this at 24 months. And so often when I'm asked in clinic, a patient will say to me, well, how much weight do I need to lose? And when we looked in the literature, it's between 3 and 15%. But actually, when we started to really work on the data, we find that actually patients needed to lose at least 24% of their body weight to get below the threshold of a lumbar puncture opening pressure of 25. And that's what we defined as disease remission. And again, when we look at these changes in body weight, you typically need to be allocated to the bariatric surgery arm for you to achieve that level of intracranial pressure. Now, the study was really well tolerated. Most of the adverse events were in the placebo arm, were usually by exacerbation of the IIH. We had no patients undergoing emergency surgery. We had one event in one of our bariatric surgery patients who had a mesenteric stitch that was sorted within 24 hours with them being admitted with a diagnostic laparoscopy, and there was no deaths within the group. And so bariatric surgery arm among patients with active IIH has really favorable outcomes. It has sustainable outcomes in terms of intracranial pressure, disease remission, and also quality of life measures. And this level that we have now determined is quite surprising. Those patients with a higher starting weight typically need to lose more weight to put their disease into remission. And I just wanted to highlight in the last few minutes some of the sub-studies that we did. One of the sub-studies looked at the impact of intracranial pressure on cognition. And this has long been debated in the literature as not that we've detected cognitive problems, but they have not been reversible. And how does that affect our clinical measurements? And so here we were able to recruit 25 control patients who were matched for age, gender and body mass index. And they kindly underwent the same baseline investigations, including lumbar puncture, so that we could assess a number of different things. And using a bespoke battery, we really were looking at attention and working memory and executive function and short-term memory. And what we saw was acutely post-lumbar puncture that there's an improvement in patients with IIH with attention and also executive function. And over 12 months, as the ICP improves, you get improvement in verbal short-term memory. There were many factors, as we would expect in this disease, that affect cognition, including some of the comorbidities we see with IIH. But what was really important to us was this ability to perform a visual field, and this was measured by the false positives, false negatives, visual field index, and test duration. So we really have to be thoughtful with our patients when we're putting them through multiple tests, particularly when the disease is very active. Now, within my title, I had per ardua ad astra, through hardship through the stars. And some of you may know that idiopathic intracranial hypertension shares some similar features to what astronauts get when they get optic nerve edema. And while our astronauts are a population that are not overweight and obese, that also mirrors some of our patients in clinic. About 10% of my patients in clinic are not overweight and obese. So while the IH weight study and bariatric surgery was very successful here, we've got to be able to do better. And what I wanted to show you is some of the new work that we're bringing through from the lab. We've been able to identify GLP-1 receptors within the choroid plexus. We know that GLP-1 receptor agonists are used to treat diabetes since 2005 and are incredibly well tolerated. We were able to show in animal experiments excellent intracranial pressure reduction, particularly when you compared them to things like topiramate, Diamox, spironolactone, and there's a really good dosing response. And we've been able to move this through to a phase 2 study. And this phase 2 study is really nice because what we're doing is we're using really high fidelity intracranial pressure monitors that sit within the right frontal lobe. It's a 10-minute procedure and it gives us highly accurate intracranial pressure monitoring. And this phase 2 has showed that we have really fantastic reductions in intracranial pressure, not only at 2.5 hours, 24 hours, but all the way out to 12 weeks. So we're very excited to be bringing a phase 3 randomized controlled trial to the UK and hopefully worldwide. And I just want to finish by thanking my wonderful colleague, Professor Alex Sinclair, who is a clinical scientist, and also all the clinical team at University Hospitals Birmingham who helped deliver the work, and all the academics within the programme. I'd like to take any questions.
Thanks very much, Susie. If you can stop sharing, that would be brilliant. Although, yes, that was a very good quick advert for UNOS.